Well, good afternoon, everybody. This is Laura Sparkman with APS. I am the Vice President for Clinical Effectiveness, and welcome to our conference call today. We're very fortunate to be joined by Keila. She's going to be introducing herself, Keila Torres from Auburn Medical Center. She's going to be introducing herself shortly here. Welcome, Keila, and if you wouldn't mind just taking a few minutes to introduce yourself, and then I'll kind of set the stage for what we're going to be talking about today.
Sure, thank you. I'm Keila Torres. I'm currently the Clinical Director for Women and Newborn Services at Multicare Auburn Medical Center. I have been a nurse for the last 11 years, been in my current role for now close to 3, and prior to that in another life, I was an attorney.
Well, thank you so much. We're thrilled to have you here. So Multicare has been a utilizer of GNOSIS for a while. What we're going to talk about today is what is GNOSIS. I'm going to go through and give everyone on the call. We have a mix of individuals that have joined us today from very large health systems, individual hospitals, frontline clinicians, risk professionals, etc. So we think that this is the content we're going to cover today is going to be a good mix of all. What Multicare really represents is an organization that has really a high-performing organization and a really good culture of project improvement. And so some of that you're going to hear today. I would, because we have a variation in professionals and background on the call today, I would be listening in for some of the cues around leadership support, transparency, the overall process of engagement and adoption and management of an effective program utilizing GNOSIS. So again, what we're going to talk about, what makes GNOSIS different, what impact does GNOSIS have, why is education in OB important, and what are best practices to engage the clinician. We really have 2 products that we offer right now, Proficiency and GNOSIS. Proficiency is around onboarding and hiring, and GNOSIS is really what we're going to dive into today. What's unique about GNOSIS is that we're an assessment-based, individualized learning platform that delivers analytics. So we measure knowledge and judgment, which is a measure of clinical proficiency, based on results of the assessment. You, as an individual learner, get an individualized learning path that you complete based on your results and what you need most. It's prioritized. And then you also get to see how your results compare to your peers nationally. We have a very large database around that, but it's also an opportunity to say, where do I need to improve as an individual, and where does my team need to improve? There's multiple ways to look at the data. This is an example of a standard scatter plot that we have. Again, we measure 2 primary variables, judgment and knowledge. And what you're seeing here is the scatter plot of the U.S. with the gray dots. We can hone in on one system, or we can show you multiple facilities in a large multi-health system, and or where your hospital sits compared to that large database, as well as individual clinicians, which represent those green dots. Ultimately, when you reassess, you're seeing here animated improvement, and that's typically what we see from assessment 1 to assessment 2. There's also an efficiency factor related to utilizing GNOSIS and our model, which is assessment-based and then learning, because you're only getting targeted focused education on what you need and what you need most. It's very typical to see 50% reduction in seat time for nurses and providers in any one of our assessments. We're also seeing increased engagement. So compared to traditional learning, what we would describe as roll and scroll, where you read a paragraph, you take a post-test, we've done a study that shows nurses and providers have increased their time significantly in the learning content, which as clinical leaders and lifelong learners in healthcare, that's exactly what we want to see. Here's an example of some de-identified data of a real client. Each of those orange boxes represent a facility in an 11 hospital system and their baseline assessment. So you're, again, looking at the X and Y axis, judgment and knowledge scores, with the black triangle representing the health system overall average, which you can see is below the APS national average for this particular peer group, which is nurses. That's baseline assessment, and after completing their assessments and their learning paths, this is second assessment, and you can see the improvement in all hospitals moved above the APS national average for knowledge and judgment. So why is obstetrics, in obstetrics, why is this important? I think I think we can safely say it's difficult to separate risk and clinical in this clinical space. Some of the common allegations, and again, this is based off of Harvard Risk Management annual review of their claims, which actually is a footprint for the country. Delays in treatment of fetal distress, improper performance of operative vaginal delivery, improper management of pregnancy. These are the common reasons. And what contributes most to OB claims? Substandard clinical judgment, miscommunications, errors, etc. So our content covers those high-risk areas and those high-risk factors in all of the high-risk areas of OB. And again, what we are seeing from our clients, these are published reports. We've seen a decrease in obstetric claims, a 67% in one of the largest health systems in the country. And we've also seen the severity of the type of claims decrease as well. We could provide you the detail on these two studies. Please just let us know and we would follow up with you. Additionally, regarding ACOG's Committee on Patient Safety and Quality Improvement, a couple of the key factors that the Joint Commission, ACOG, AWAN, several organizations in the country have come together around, which is a culture of safety framework, and any effort to reduce medical errors is a high priority, right? So a commitment to safety that permeates all levels of the organization. So again, this is an enterprise-wide solution for physicians, nurse midwives, residents, nurses, etc. And that communication among all team members is crucial to reduce adverse events and improve patient safety. And I think we all know that anecdotally, but we're actually able to now demonstrate that because the way this education is delivered and the way that we're providing data to you. We're doing some very unique work with AWAN. We have a partnership with AWAN. They've validated all of our OB content, but we're also involved in a very special project that's actually launching this month called Mothers and Babies First. It's about a perinatal safety improvement project, reducing maternal mortality and decreasing OB adverse events together. There is a physician component to this. We're working with physician leaders, of course, because this is a team-based service area, and it's important that all physicians, nurses, midwives, etc., are learning on the same content, but then again, supporting and doing each other and doing other elements of education such that follow foundational education like GNOSIS, simulation, and team training. So, Keila, I'm going to hand it over to you and let you kind of take it away and tell your story.
Sure. Well, happy to be here and hopefully share our path with GNOSIS for the past year. To give a little bit of a historical background, AMC Birth Center and NICU joined the Multicare family close to 4 years ago, and in that time has had a very rapid growth in terms of deliveries and NICU volume. This translated into a need for figuring out how were we going to ensure that as we were onboarding all of these new nurses, new providers in the Washington State area, like in many parts of the country, it's been really hard to be able to get experienced OB nurses, so we're in a position to having to grow them. And when you are in a situation where you have 30 to 40% of your labor and delivery nurses being fresh grads, this can present some anxiety and some concerns with respect to, are we doing everything possible to ensure that we have safe patient practices, that we're minimizing risk associated with judgment issues, knowledge issues, and so forth. And so for this, I started thinking, okay, what can we do that can help the team? In a prior organization, I had used GNOSIS, and we've had a really good results. I was in the same situation in that I did have experienced nurses, but the product itself seemed to be something that we needed here. So I approached it first in terms of getting leadership buy-in, and what did that look like? Well, I went to first to get senior executive sponsorship, as this was going to be, a costly endeavor for our organization. And I presented our situation, what would we be getting out of it, really did a cost benefit analysis and got buy-in from at the executive level. Then I actually sat down with medical leadership and said, okay, this is not just about the nurses, this is about the nurses and our providers. As we are a team, we collaborate in the management of these patients. We have to be all in. It can't just be a nursing initiative. And they agreed. Did a lot of the discussion with respect to how this was a win-win, not just for our patients, but also for the team as a whole, as they themselves had been asking for, how do we get additional training? Do you think we're doing enough of the drills? How do we get the staff to feel more comfortable and confident? And was able to kind of like bring that back to the group and say, okay, I'm hearing the same messages throughout, so we need to approach this as it's not just about the nurses, it's not just about the providers who's more competent than the other, but rather we together are going to embark in this journey. And that's what we ended up doing. As you can see here, we actually had from our provider group, and just to clarify, when I'm referring to providers, we have our physician employee group. We also have a group of family practitioners, midwives, and residents. And we actually reached out to all of them and asked that they participate. We had our highest participation from our employee group and are working on increasing the ones from the family practitioners. Time turned out to be an issue, but they're very committed to completing it. And here, what we were able to do was actually show the data. So we developed a plan on how we were going to roll it out. I was able to show this was the first module that we assigned. We were very ambitious in trying to assign all 4 assessments in the first year because we wanted to get a baseline of where we were at. And I was very clear in the planning for the implementation with all groups that this was going to be, it was going to feel very time intensive for this year, but that what it would give us in the long run would be very much worthwhile because we were going to use it to really address a lot of our perceptions and get an actual impartial assessment, evidence-based, on where we were at that would then help to drive our future practices and our education offerings. So one of the first things that we did is I partnered with our system educator, and we identified super users for both the nurses and the providers. We all did the training together. Some of the concerns that arose, especially from the physician group, even though they were bought into the importance of doing it, there were some concerns about, okay, is this going to be used or tallied into my performance evaluation or my possible compensation package? And I made it very clear that this was really about us figuring out where we were at as a team, that the individual scores were not going to be released. They would know it, but I wouldn't know it. Only the educator as a impartial party to all of this would know it, but all of the reports and the things that I would share with the group and that would be generated for me would be blinded. And that really, really made a difference in terms of their participation. From the nursing standpoint, I was very clear that it's mandatory for you guys, so guess what? It's also mandatory for our providers. And that actually was their biggest issue. You know, don't have us do something and then they don't do it, because it's still going to then be an issue when we're at the bedside and we're reading strips or we're quoting to things. And so there might be some friction if we're not all on the same page because we all haven't been educated in the same way.
Kayla, this is Laura. I think you're raising a really important point. There's probably a lot of heads nodding right now. We hear that as a common, concern too around the balance, what we require nurses to do versus what we require providers to do. Can you talk a little bit about the leadership support behind, making that happen?
So I really have to give a lot of kudos to my medical director. We have an OB steering committee where nursing leadership and our providers meet. They actually voted to make this a mandatory requirement and understood the importance of it. And they applied peer pressure to, hey, it's really important that we do this. We talked about, yes, we know that time was going to be an issue, even more so for the providers because a lot of them did this on their free time. And they have a pretty heavy load. But as they started seeing the need for it, when I was able to share the fetal assessment and monitoring results, because they were like, oh my gosh, that's really how we score. I thought I was much better than that. So that already, they were like excited. I would get texts at home, hey, I'm not able to log in, or did you release the hypertensive disorder one? We had put out a memo with here are all the deadlines that are coming up. We had this crazy surge during the summer that required us to reschedule some of them, but we kept informing throughout of where we were at, not just in terms of the results as we worked through the modules, but also how many people were participating, and that was a big driver. I was able to go to my nurses and say, hey, in this module, providers are already at this percentage of completion, and you guys aren't, and they're like, what? No way! And so that communication went back and forth because a lot of type A personalities in my department, and competition, especially healthy one, was helpful. Another thing that we found was the conversations that were happening. I would go by the nurse's station and they'd be talking about strips or, hey, did you complete this module because I got this question and I thought it was about this, or what do you think about that? Requests being made to me of, hey, can we do a code that emphasizes this, or why was this topic included in this? If we do more of this part of management of the patient versus the other, and it's like, well, because you're a team. So you have to be aware of your role and your teammates' role in the management of the patients. Going back to our relationship with our system educator, as we implemented the various modules and they were rolled out, at the end, at the due date, around the due date of each module, we had scheduled a drill, mock code of sorts, that would emphasize what we had just basically taught online. And that was great, to emphasize what they had just learned, to be able to see, were they able to translate some of this into a practice setting. And that's something that we're going to continue to replicate moving forward, just that alignment of, okay, you went and you did something online, but now let's have some hands-on practice.
So this utilization report that's on the screen now, it sounds like you had a lot of transparency among the team, showing providers and nurses where each peer group was. That created some good fodder for some competition, right, based on what you're saying?
Yeah.
Based on that, I mean, how much, kind of hands-on management did you really have to, go chase the cats, if you will, to complete, and or you're managing completions?
Not as much as I originally thought. I thought it was going to be more labor intensive. I would receive the reports. When we go back to, executive sponsorship of it, one of the things that I did was I had to report out monthly at our Women's Collaborative, which is our big system meeting, all of the hospitals, other women and newborn services. We talk about our different initiatives, and so this had been a standing topic. So if I didn't have anything to report because that month the modules were not due or we didn't do anything, then I would just say, okay, it's ongoing, I'll report something out the next. So that accountability at that level, and having a mixed group of leadership throughout the system here, it really made me have to streamline the process. And also that let the physicians know that, hey, other people are listening. And for my nurses, even though they don't participate in that meeting, they knew that I was reporting this all out. And I was very transparent in the economic commitment and time commitment, because if they weren't able to complete this during work hours because there wasn't any time, there was education dollars that were built in to our budget to be able to accommodate that. So I made it very clear that I am happy to invest this, but it is an investment, and I have to show a return of investment, not necessarily by the scores, but more by your participation and engagement with the program.
Great. Okay.
So then how do we celebrate the successes? I think two things that we focused on were, isn't it awesome that everybody's participating? And hey, look at the areas in which we've done really well. Look at our areas of opportunity. Noticing how sometimes, the nursing group had more strengths in one area versus the other. As you see, kind of like there, it was great to actually, when I presented this to in our steering committee, they're like, oh my gosh. I try to do it in a way where it wasn't really about who was better than another, but rather us as a team, how we were moving forward, and if there were things that we were really good at, then how could we maintain, sustain, and if there were areas of opportunity, okay, then these are going to be our targets. We also talked about, okay, what else are we going to do with this data? What if we have a lot of outliers? And so that discussion was really led by the medical directors in terms of what was accountability going to look like in that group. I shared what it was going to look like for nursing, right? I was holding our nurses accountable to completing it, and if we saw a lot of outliers, then the educator was going to develop some specialized plans, and the physicians committed to something similar to that. We agreed that if need be, unblinded reports would be sent to the medical director, and they were going to follow up. In addition, if we were having risk analysis and noticing some trends, then we would be able to dig into this data and see, hey, is there a correlation between what we're seeing on the floor and the staff involved, and what can we do about it? So it's really been used to not only educate and reinforce what we're doing well, but also to identify our gaps, and more importantly, to just have, like I spoke to in the beginning, that baseline that we can continue to draw upon. Because it's great to have something that will serve for your game plan moving forward than just kind of like plucking it out. Here's a slide where you see some of the variation, and it really hit home with them, and it marked maybe some differences between obstetrical providers versus family practitioners. How long has it been since you've done certain modules? Were you really that focused? When they first saw this, they're like, okay, so what does that mean? And I said, okay, remember, this was the first assessment, so what I'm expecting when we do this next time around is that there's going to be an improvement. We don't see movement, or we only see partial movement, then we're going to have to start doing the drill downs.
Right. So it sounds like your improvement was really focused on reducing the variation among the practice standards, right, from the providers and nurses. It looks like on your nursing slide, you do have a good group of nurses in that upper quadrant, but several that are below the line that you might consider to be outliers or extreme outliers. How are you managing them in kind of a blended model of education for those individuals that after they complete their learning path, what are your expectations for them?
So that let us know as we did the deep dives. We had a lot of residents sitting in there, and that kind of like made sense. And some of them had actually just been fully on the floor for 3 to 4 months compared to the ones that have been in nursing for 15, 20, and 30 years. So we have developed peer mentorship programs, having our more experienced proficient nurses kind of mentor our younger ones. And what we've also done is develop modules and kind of like case studies and interactive things in the unit. What I committed to for this first year, I wasn't going to focus as much on the individual score, but rather take this as, okay, this is where the group is really lying. This is where we're going to move as a group. And in the second year, especially since we're repeating the fetal monitoring in the hypertensive one, which is the one that tends to show the biggest variations and the most applicable to the patient population that we're currently seeing, ones we felt gave us a little bit more heart palpitations. So we're repeating those this second year in 2017. This year, it really is about the individual accountability if we don't see the group as a whole moving forward. And I've been pretty transparent with the expectations.
So your lessons learned, and you've kind of gone through that a little bit, but kind of
Definitely
what's the
communicated throughout. Feedback that staff provided. It was great that you gave us a summary with the due dates for the memo, but we still need you to send reminders. So this year, not only am I sending them the invites, putting it out in various forms, I'm also going to make sure to put in tickers that as the dates approach, hey, course launched today, hey, you have X amount of days, because they really said that it just helps keep it in their mind. Giving people the data and an opportunity to think about it, to have robust discussions, really made the program feel more real and relevant to them, and just really emphasizing that, hey, this is a major education assessment tool for us, so we really need to make it a priority to utilize it. I was very clear for those that straggled along in completion on all groups. I said, okay, we need to address what barriers there are for your completion, because not having you complete your part, guess what? That means that I don't have a full picture of what's going on in the department, and that's going to hamper our ability to address what we need to address, because it could be that maybe a couple of more scores change what we thought the focus would be. So continuing to tell them why it was important that even, that you as an individual contribute to the overall group assessment hit home. So they're like, oh, really? I didn't think about it that way. And it's like, yeah, this is bigger than just your individual result. This is us as a team.
Great story. Anything else that you might share, anecdotally, any stories with any clinicians,
Sure. So if you saw the slide there that saw the physician participation, right? And I finished telling you, hey, we had a great participation rate. Well, when I did the deep dive, like I said, we saw high participation from our MMA employed. We saw our family practitioners kind of like 50%, so that brought down that piece. And then we saw the residents at 45%. I'm like, oh my gosh, if anybody, the residents should be doing it. This helped us identify that there were just some barriers that we hadn't even thought of, hey, guess what? They have no time built into their programs to complete this. So how do we help them? And I'm happy to report that one of our physician super users is actually working with the resident groups to say, hey, we think we, as the people who are basically mentoring your students and providing these residencies, think it's really important that they complete this in their first year residency, and how can we help you get this done? So having those conversations that I didn't even have to have it physician to physician and saying, help me help you, I thought was completely awesome. Because at first glance, it made it look as though, oh my gosh, this group is so not engaged, and that wasn't the case. I had actually residents come up to me and say, hey, I figured out a way to complete it. I'm trying to, or help, I don't have enough time. So, learning moment.
That's great. So we're near the end of our time. Keila, I want to tell you thank you very much. I do, as I'm listening and learning about your process, again, what comes to mind for me is that, it's kind of a top down, and then you have to cycle back around, right? Kind of like the IHI improvement model in many ways, which is you get that leadership buy-in, which it sounds like you did a wonderful job and you were leading it, and you had that high level support, but then the ongoing communications, the transparency in showing data and results, and about there's no blame and shame. It's about team-based improvement. And I love that one point that you made. You use it as a recruiting tool for nurses to say, we're invested in your success. And I just think that's such a positive piece, we don't often hear about. So it sounds like a great program you're running there.
Thank you.
This is Tom. We got a couple of questions that came in. We are having trouble getting buy-in from the residency director. They're concerned it takes too many hours. What is the average amount of time your residents spend completing the program?
So actually, everybody completed the modules quicker than the time listed there. We had some resident directors that originally felt that way, and what we shared with them is, guess what? You're expecting us to provide, right, and hands-on learning experience to your residents, but we're getting some residents that are really green and don't really know how to read a strip. So why would we not have them do the A1 module throughout and equip them? Because at the end of the day, this really translates into an unsafe environment for the patient. And we had to share stories of, hey, here are some of the situations. So do we want to freak our residents out and our staff who will lose confidence in co-managing patients with the residents, or do we want to help grow them and grow their confidence?
Actually, I'm going to echo that. I have some data here. So across the APS average of tens of thousands of assessments and learning paths, for providers, 3.2 hours for fetal assessment and monitoring, 2.8 hours for obstetrical hemorrhage, 1.1 hours for shoulder dystocia, and 1.3 hours for hypertensive disorders in pregnancy. So you're looking at, yes, it's an investment, but it's probably not, because of the reduced seat time, it's probably a little different than what traditionally people have in their heads. So once you can communicate that in front, that's part of the buy-in, I believe.
And can I add something else? The other piece that was a big selling point when time was put out there was that they could do it in snippets. So the cool thing about the program is, as long as you finish one part of, you start a module, you finish one section, you can save and come back to it. So that was a huge selling point for our providers, because I could say, you know what, sometimes in shifts you do have those up and downs, and you have some time to take a breather. You can go in and do a section, focus, let it be, go back to what you were doing.
Other questions, Tom?
How often are you assigning the courses, for example, FAM?
So the fetal monitoring, I assigned it the first year, and I'm going to assign it the second one. I look at the program as this 3-year. So the first year was my baseline. Fetal monitoring will go again this year. The next year, I think I'm doing fetal monitoring hypertensive this year, and then the next year will be the other two, so give a year in between. And even my assignment of 2 this year, I pushed it to later in the year, just to give some time for it to truly marinate and for us to do our hands-on drills and whatnot.
And then the other question is regarding the team culture. Having providers and nurses both take a standardized education, they're both taking basically, there's a track for each role, but taking the same standardized courses and education, how has that had impact on culture in general on the unit?
It's been great. I'm happy to share that both physician and staff engagement is in the top quartile. My physician engagement is in 92nd percentile, and my staff engagement in the past years has been 90s to 80s. So they are really see this as it's our department, it's our responsibility to work as a team. We're in it together.
That's nice. Are you seeing that play out, collegially on the floor, the teaming, the behaviors, the interactions?
They talk to each other. I hardly ever have to get involved in anything related to figuring out how they're going to manage a patient.
Nice.
Because they have the conversations amongst themselves.
All right. Well, again, Keila, thank you very much for your time and sharing your story with us. If anybody has any questions for us, there's our web address and phone number. So thank you, everybody. Have a great rest of your afternoon. Again, Keila, thank you, and we will be talking with you soon.
Welcome.